Hello again. My name is David Hurtado. I'm the faculty host of today's seminar, and I'm very pleased to introduce a friend of the Institute, Dr. Marissa Baker, who is an associate professor in the University of Washington Department of Environmental and Occupational Health Sciences, where she also serves as deputy director of the Northwest Center for Occupational Health and Safety. Um, Marissa's research, Dr. Baker's research, centers on occupational experiences of vulnerable or underrepresented groups. Trained as an industrial hygienist, Dr. Baker has expertise in workplace exposure assessment, using techniques such as air sampling, biomonitoring, and exposure modeling. Recently, her interest and expertise have expanded to characterize stress and mental health in working populations using both survey and qualitative methods. Marisa, thank you so much for joining. It's wonderful to see you again, and we've for those who attended the Workshops on Health conference in Seattle, it was fantastic to see your um, um, panel there, and I'm just delighted that you're here. So yeah, welcome and take it away, please.
Yeah, thank you, David. It's great to be here. And so today I'm going to talk about something of a little different flavor than some of the work I talked about at Work Stress and Health, if you were there. I'm going to be talking about a project I did assessing exposure to fentanyl and methamphetamine on transit here in the Pacific Northwest, including in Seattle and in Portland. However, there is both a physical and mental health aspect to this to learn about. So just to disclose, this project was funded through a contract with Sound Transit, but also we received funding from King County Metro, Community Transit, Everett Transit, and TriMet. However, the findings I'm reporting are those of mine alone. They do not necessarily reflect the official views or positions of the agencies who contributed funding. So to kind of get started, living in Seattle and you all being in Portland, these are things that back in 2022, you all probably saw. So there was a lot of news, popular press kind of looking at, we're in a state of emergency over fentanyl. There's metro operators are concerned by drug use in buses. And we are seeing this both in Portland and Seattle, these kind of big news posts looking to kind of fuel the outrage around fentanyl use on transit. So given that, and given some of these other factors, so there was a change in how drugs are consumed. There was kind of a move from injecting some of these drugs to smoking them. There was increased accessibility. The use was decriminalized in various ways in Seattle and Portland and other West Coast cities. Both operators and transit agencies reached out to my department, Environmental and Occupational Health Sciences, and wanted help on assessing exposure on transit and the controls that could be available to protect operators. I will note that we also received a list of more than 1,500 recorded complaints from Seattle transit operators in 2022, where they characterized their experiences with folks using drugs on their buses and the physical and mental health outcomes that they experienced. Many of these were actually submitted to workers' compensation in Washington state and were accepted for both physical and mental health outcomes. So the project that we did with the transit agencies, we did an industrial hygiene exposure assessment, and we looked for fentanyl and methamphetamine on the transit vehicles. And to do this, we collected both air and surface samples from 11 different buses across 4 of the agencies and 19 train cars. And we collected these samples between March and June of 2023 over about a month long, over about 28 nights, so a month of days. We worked with the agency partners. They helped us identify what routes, runs, and time of day we should be sampling. And we were looking for when the smoking of these substances would be most likely to occur in order to kind of increase the chances of finding this happening so we could accurately characterize the exposures. We made sure to collect air and surface samples at or near the operator because this was an occupational health project. We were interested in the exposures that the operator faced, but we also collected samples in other areas throughout the vehicle where smoke would be expected to accumulate. So kind of in the rear of the bus and in certain areas on trains that TriMet and Sound Transit staff showed us people like to congregate. So I want to be very clear about what the assessment did not do because it was an exposure assessment. It was not, we did not formally characterize short or long-term health outcomes that were associated with secondhand exposure to fentanyl or methamphetamine. And also, we did not collect any internal biomarkers of exposure. So we did not collect urine or blood from operators in order to understand how the air levels we measured related to what entered their bodies. And the reason we did not do this, and this is a question I get quite frequently, there's a few, but one, we didn't know the timing between when someone would be exposed and when we would expect to find it in urine or blood. And in order to adhere to timing, we would have to interrupt shifts, we would have to interrupt service potentially, or sleep schedules, things like that. In addition, there was concern from the labor side that if we did not find something, that the agencies would then kind of not take any concerns seriously that the operators had. And there were also concerns on the agency side that if we did find something, it could potentially undermine their DOT drug testing. If, you're able to say, oh, someone was smoking on my bus, that's why there's, a illicit substance. So we pretty quickly dropped the idea of a biomarker study for this project. There are also a few challenges we really had to confront up top, and I'll go through some of these in a little bit more. So there are no enforceable occupational exposure levels specific to these contaminants. And so some of it, we could measure it, but it was challenging to interpret it, what it meant for worker health. And because of that, there are no validated methods for how to best sample for these contaminants. In addition, our sampling equipment couldn't be visible or accessible to the writing public. One, because we didn't want it to get swiped, but also because we didn't want to create fear or outrage as to what we were doing on the buses. On the flip side, we also could not be on transit with our equipment. That would induce bias. And then because we were not with our equipment, in most cases, it was hard for us to determine the circumstances of exposure. So if we found fentanyl in an air sample, we don't know how long the person might have been smoking, where they were smoking, how many smoking events happened over a time period. We just know that we found fentanyl in the air. So I do want to talk a little bit about guidelines, exposure guidelines that informed this project. And I'll start by describing what the ACGIH TLVs are, or threshold limit values. So these are developed and updated by a highly respected group of occupational hygiene practitioners and researchers that come from academia, government, industries, and unions. The ACGIH stands for the American Conference of Governmental Industrial Hygienists. And this group get together and they write occupational exposure values for chemicals that are regulated by OSHA and chemicals like fentanyl that are not regulated by OSHA. And these threshold limit values are like OSHA permissible exposure limits and describe a safe level of exposure either over an 8-hour workday or a 15-minute short-term exposure. The documentation for these detail health effects, the quality of the data, sensitive subgroups, and the goal with these TLVs is for protection of nearly all workers. I do want to stress, and it's in big purple letters, these are different than OSHA PELs in a very key way. they do not consider technical, analytical, or economic feasibility. So these are health-based standards, what the standard would need to be protective of health of nearly all workers without regard for how that standard would actually be enacted. These are also not legally enforceable, but they are highly respected in the industrial hygiene and occupational health communities, and therefore worthy guidelines to guide our work. All right, so I share all that with you because there is a fentanyl, ACGIH has written a fentanyl guidance value, but there are no enforceable, so no OSHA, no Oregon state standard, no Washington state standard, so no enforceable airborne or surface standards for fentanyl at any states or at the federal level. But ACGIH has written both air and surface guidelines, and they are given here. ACGIH has written an 8-hour inhalable standard of 0.1 microgram per cubic meter in air and a 15-minute short-term exposure limit, which I have listed there. They've also written a surface guideline of 10 nanograms per square centimeter. So in 1 square centimeter, there should be no more than 10 nanograms by weight of fentanyl. Looking at methamphetamine, which was the other compound we were looking for, again, there are no enforceable or guideline airborne standards for methamphetamine at a state or federal level in the air. There are surface standards that are regulatory, which means that there is some kind of, you have to comply with them, and those differ by the state. So in Oregon, there's an acceptable level for decontamination of 0.54 nanograms per square centimeter. But to be clear, this only applies to drug manufacturing sites. It does not apply to transit. In Washington, it's a higher level that's allowed, 15 nanograms per square centimeter. It's unknown whether this would be applicable in a transit setting. The courts would have to decide that. It's really meant for known drug labs or transient accommodations. However, we are using these as useful benchmarks for comparisons with the big kind of caveat that they may not apply to the environment where we were sampling. So you get to see my artwork here. I also want to stress that bus drivers drive 8-hour shifts. Or more. Not much more, but they could drive more. These smoking events happen very quickly. They might only last 15 minutes. So across the x-axis here, I have the time that an operator could be at work and their exposure to drugs that they might experience over their shift is along the y-axis. And you can see these peaks in exposure that are very short amounts of time. So an 8-hour time-weighted average exposure is kind of the average, including these peaks. There's going to be potentially multiple smoking events over an 8-hour shift, but they are short with very high exposures. When someone is riding the bus, they are not on the bus for 8 hours. Typically, they might be on the bus for a half hour, 15 minutes, 45 minutes. So denoted by that blue bar. So really, it depends on when somebody is getting on the bus as to what their exposure level will be. So this person, they are on and off before with practically zero exposure because no one was smoking when they were on. This person, maybe they happened to get on right when someone was smoking, and so it's going to be a very high exposure, but they will get off. And similarly, someone could get on and there hadn't been a smoking event for hours before or after. And so all this is just to kind of stress that the experiences for a rider on transit is much different than the experiences for an operator. An operator is on there for an entire shift. We're talking about an 8-hour kind of chronic exposure, whereas for a rider, it's these shorter term, potentially, exposures. So our study was to look at exposures to operators, and so we did longer term sampling. And I just want to say that it's not applicable to the riding public. And so hypotheses that I draw for the operators, it's not appropriate to try to extend those to the riders, given that the exposure profiles and the time spent on the bus is quite different. All right, so that being said, to dig into our methods a little bit more and our findings. So the air samples we collected varied a bit by agency and type of vehicle, and a lot of that was because we had to hide the samplers in kind of unique and creative ways, and I'll show some pictures. But we did consistently collect samples that were representative of operator exposure, either on their seat, if they're a bus driver, or in their cab, if they're operating a train. And then we collected air samples elsewhere in the bus as well. We aim to collect air samples for 4 hours to inform our 8-hour time-weighted average exposures. We found from the lab that after 4 hours, the sample started to degrade a bit, that we didn't want to collect for longer than that. To make this a little more industrial hygiene for you all, these are the nitty-gritty details. We used SKC AirCheck 5000 pumps, which we calibrated to 2 liters per minute, and we collected in these cassettes that are shown on the right, which are a 3-stage cassette. We also took blanks with each sampling day. For our surface samples, again, these also varied by agency and type of vehicle as to where we were able to collect them. For example, on Sound Transit in Seattle, at the end of the line, everybody is asked to get off the train, so we were able to kind of sample wherever we wanted. With TriMet, people can stay on the train at the end of the line, and so if someone was, sitting in a seat, we weren't going to come in and ask them to move in order to sample. But we consistently collected samples near the operator. Most of our samples we collected in predetermined and pre-cleaned areas. So we got on the coach or train, we pre-cleaned an area. So this would really answer the question, how much drug residue deposited on these surfaces during the work shift? However, there were other instances where we collected kind of out of curiosity. So, we would find paraphernalia, or we would sample high-touch surfaces or in the ventilation. These were not areas that were pre-cleaned or pre-planned. So that's really answering the question, how much drug residue has deposited in this location since a previous deep cleaning. And here's some pictures, a little blurry, of how we collected those surface samples. We rubbed a methanol wetted swab over a 100 square centimeter area using a template. You can see the swab there on the left. We then stored that swab in a capped glass container that was sent to the lab, and the blanks, we collected blanks on each sampling day. All of our samples were sent on dry ice to Bureau Veritas lab in Lake Zurich for analysis. They have an OP alert method using LC-MS-MS. Like I said, the reported recovery decreases after about 4 hours of sampling. So that's why we tried to limit our samples to 4 hours. And most of them were collected for the 4 to 5 hour period. This picture just shows an example of what we would find on transit when we went to collect our samplers. It was kind of obvious, prevalent drug use. Here's some pictures of how we hid our air samplers on transit. And this, to me, was probably the most fun part of the project. It felt good to be really creative about how we can sample while also, concealing our equipment. So you can see, for example, we had this little box with magnets that we could put behind the wayfaring sign in the middle of the bus that our filter could stick out of. In the back of the bus, we 3D printed, one of our partners 3D printed those little covers that kind of look like speakers. And we were put in a false panel, so we were able to hide our equipment behind the false panel and collect air through the speaker. Others we hid in the ventilation, and you can see how we, had a sampling pump on the driver's seat as well to collect samples in the buses. Here's some pictures of how we collected with the train. There's the team down in Portland collecting samples on TriMet. But on the left, you can see that we would put the pump in the driver's cab, and we created this false panel or it's a real panel that in the door that separates the driver's cab from the passenger area, cut a hole in it so we could point the filter out into the passenger area, and that's how we collected the air in the passenger area. So just showing some of kind of the creative thought that went into how do we collect these samples in a very public environment while protecting our equipment and not, kind of fueling questions around what we're doing. So here are the results of our sampling for fentanyl. And I'll say that our results tended to be higher in the rear of the bus or the passenger area of the train, which is where drug use is most frequently reported. And we have this broken down by the buses and the trains, by the operator area and the passenger area or the rear of the bus. And we found one sample that was above that fentanyl the fentanyl ACGIH TLV that I spoke about. I have that highlighted here in red. It was in a passenger area on a train, and the corresponding operator sample taken in the operator cab at the same time was at about 80% of the TLV. So there was kind of evidence that there are scenarios under which this fentanyl ACGIH TLV could be exceeded for train operators. And then for methamphetamine, these exposures also tended to be higher in the rear of the bus or the passenger areas. I want to stress that fentanyl and methamphetamine levels were not correlated. So it does seem to potentially be, different use patterns. What I am highlighting here is that we found methamphetamine in every sample that we took of air. You can see under the percent that we found there. You can see the range. Again, we don't have air guidelines to compare this to, so it's hard to say whether these are high or low, other than to say that they were higher in certain parts of the vehicle and it was found in every sample. So to conclude the air sample results, of the 78 samples we submitted for analysis, a quarter had detectable fentanyl and all of them had detectable methamphetamine. One air sample exceeded the ACGIH guideline that I talked about. And the next highest sample was at about 80% of that guideline. And exposures tended to be higher in the rear of the bus or passenger area, but there is evidence of migration to the operator because we were able to detect at the operator as well. But values are not interpretable for the writing public. These are full shift samples. I also want to just quickly think about short-term exposure. So there is that ACGIH short-term exposure limit of 0.2 micrograms per cubic meter. So we were able to use total masses from the lab, which were given to us in nanograms. And using those, we tried to calculate what a short-term exposure level might be if that mass had been generated in 15 minutes. So if that mass had been solely due to one smoking event happening in 15 minutes, which would be 30 liters of air. So we were able to take the mass and divide it by 30 liters. We don't know if that's what happened. It's not out of the scope of possibility. But from that exercise, 7 of the 20 air samples that we took for fentanyl did exceed the ACGIH short-term exposure limit, with the highest calculated STEL being 2.2 micrograms, so really exceeded by quite a lot. But these exceedances spanned all agencies and locations. So this is something that I think further research might be warranted in kind of these short-term exposures and how high it can get, and what's the time, how long does it take for them to clear out and things like that. So here's some pictures of surface samples. Here's some team members collecting them on backs, on high touch areas like the handlebars, and the backs of seats are kind of around the seats. And kind of our findings from the surface samples. So fentanyl was detected on about half of the surface samples that we collected. We collected 102 across the 4 different agencies. It was highest on paraphernalia, door handles, and in the rear areas of the bus, but no samples exceeded the ACGIH surface limit of 10 nanograms per square centimeter. We detected methamphetamine on nearly every surface sample that we collected. It was highest inside the bus vents, and the picture on the right there shows me collecting a sample in the bus vent. You can see that it's quite dirty in there, and there was very high meth, well above any state decontamination limit, which again does not apply in this situation, but still well above it. And 5 of our wipe samples exceeded the highest state decontamination guidance we were working with, which was Washington State, for methamphetamine. We also did a small analysis to see how what the environmental levels were in Washington and Oregon off of the buses. So in order to do this, we took repeat environmental air and surface samples from 3 locations in Seattle: an urban location, a suburban location, and a more residential area, and then 2 locations in Oregon, one downtown Portland and another in Clackamas, by our hotel where we were staying in Clackamas. So, and here's kind of some pictures of how we did that. We were kind of rigging up our vehicles so we could leave our pumps unattended for 4 hours, or the one in the middle, that's on the roof of our building at University of Washington, using that magnetic box again. Of those samples that we collected, we did not detect fentanyl on any of the surface or air samples. We did find meth on maybe 4 out of the 16 air samples that we collected, but it was about 1,000 times lower than it was found on transit. So this kind of, from this, we concluded that it's likely not the background that's driving its presence on transit. It's likely the activities that are happening on or around transit. So we had the opportunity to give recommendations to agencies based on our findings. And our first was to continue to work with their unions and their workers for input into the response and controls. This problem and concern was really raised by the workers, so continuing to include them as a partner in how to, solve some of the concerns is important. We also, public health has long had the goal of smoke-free workplaces. And so we feel that consistent with that public health goal, we should discourage and enforce drug use on transit, with the important caveat that we do not want to enact further harm to the users, but we also recognize that the operators need to have, feel like they can be safe on their at work and are breathing in clean, safe air. We suggested upgrading ventilation to MERV 13 on buses and trains as able, and I'm pleased to say that the transit agencies have largely done that. We suggested enhanced cleaning protocols where you're increasing the frequency of cleaning, making sure that you're using the appropriate solvents, and doing more frequent deep cleaning. This is another area where the transit agencies have really done a lot to enhance their cleaning protocols. We also suggested specific training and considerations for the operator around amending the agency protocols, like when they can take breaks and how they report problems, how to keep them safe, kind of what's the real risk here versus the perceived risk, how they can access mental health supports, things like that. What we found is that this really is a concerning psychosocial exposure for operators. They don't feel that they can safely do their jobs if they have one eye on what people in the back of the bus are doing, or if they're concerned that someone is going to overdose on their bus and they might have to administer Narcan, or maybe they don't know how to, or maybe they don't want to. And so while there were, like I said, workers' comp cases that were accepted for physical health outcomes, really these levels are not what we would expect to cause kind of major health outcomes for operators. However, the anxiety they felt, the panic they felt, the fact that they felt they couldn't be safe at work were very real things that were due to observing this. And so that's kind of, cleaning protocols and ventilation are going to clean the bus and the air, but it's not going to prevent the root problem of a driver feeling unsafe, because they are responsible for a bus load of people, and they're having to keep one eye on the back of the bus instead of two eyes on the road. So to kind of look at the hierarchy of controls, which we use in industrial hygiene to control hazards, I popped those ideas onto the hierarchy of controls. So obviously elimination is going to be the most effective control. And that's this idea of promoting smoke-free workplaces, finding community-centered supports and environments where it's safe for drug users to use drugs such that they don't need to use public transit. Ventilation upgrades are considered engineering controls, and cleaning protocols and operator trainings are administrative controls. You will note that I did not recommend masks for operators as a control. This is obviously an individual control. There's a lot of variability in how it's enacted. You would need to have a respiratory protection plan. Operators would need to be trained. Medical clearance might be required. And it's not pleasant to wear a mask for 8 hours at work or more. Operators would need to know, we would need to make sure that they're wearing them appropriately and consistently. We have the rest of the hierarchy available to us, and we have other good controls. And so PPE is not something that I recommended, except in terms of, cleaning up drug paraphernalia and things like that. So if a transit operator walks into an industrial hygienist's office or an occupational physician's office and tells you that they were exposed to fentanyl or other smoked drugs, here's my advice. The first is to believe them. It is certainly present on transit, or at least it was in 2022 when we collected these samples. Also, just a reminder that being around fentanyl smoke or drug smoke in general is not remotely pleasant. Through my work on this project, I did spend time around fentanyl smoke and handling paraphernalia. It's not fun. It smells bad. It gets stuck in your hair. And so I think it's important to acknowledge that physical and mental impacts are possible from witnessing it and smelling it and seeing it, even as things like overdose are not. Those are not really possible at the levels we're seeing, but that doesn't mean it's pleasant. Also, I think we need to consider the full range of impacts that this exposure could have for workers and their work life. We talked about the physical, mental, and psychosocial impacts, but something else we learned is that many operators have a former relationship with drugs. And so being in a workplace where drugs are openly used can be challenging for their own recovery or for their own well-being. And overall, what I learned from this is that operators really want to be heard, acknowledged, believed, and given solutions and support instead of having their experiences minimized. There was a lot of, you're not going to overdose at these levels. But there are a lot of health outcomes that we in occupational health should be concerned about between nothing and overdose. And many of those were being experienced. So we did communicate our results. And as you can imagine, it did get picked up by news pretty local, both in Seattle and in Portland. Here are some of the headlines that came out. Some were better than others. Like, Jason Rantz saying the the UW study dismisses drug concerns to protect transit and harm reduction advocates really hurt me as an industrial hygienist whose main goal is to protect the workers and keep workers safe. But it was all over. This is just a small smattering. It went on for a couple days. And I will just say that one of the most important things that I learned from this experience is don't read the comments. So take that with you as if your work is picked up by the news or if you're interviewed. It's important to share. It's important to get your results out there and communicate results appropriately. It doesn't mean you have to engage with the trolls who want to feather and tar you, which is something that was called for on Twitter for me. This also really kind of instilled in me more interest in risk communication and how we appropriately communicate risk. So for like the last few minutes of my talk, that's what I'm going to focus on. So Peter Sandman, he literally wrote the book on risk communication, which is shown there. And he says, if people are outraged because they do not understand the hazard, educate them about the hazard. If they are outraged and do understand the hazard, you must address the outrage. Educating the public is not sufficient to deal with public outrage. And I teach Peter Sandman in my undergraduate and graduate classes. And he says that risk, how the public perceives risk, is a function of the hazard and the outrage around the hazard. And for something like this, there was certainly a lot of outrage. And that was fueled by those media reports that, showed someone touching a dollar bill and having an overdose or what have you. But it was really kind of a reminder that we have to understand what are the factors driving the outrage, and to go in and communicate appropriately as opposed to coming in and saying there's no risk, everyone's fine. Which is some of what happened with the communication. So what Dr. Sandman talks about is it's important to reassure without over-reassuring. And he says, never say anything is safe. X may be safer than Y, or pretty safe, or safer than it used to be, or safer than the regulatory standard, but it isn't safe, and it certainly isn't absolutely safe. So this is something that I held with me. We didn't want to come in and say transit is completely safe, there's no risk from fentanyl. That really just fuels the outrage more for the drivers. And so we wanted to kind of tailor our message more appropriately to say, everyone deserves a safe and healthy workplace. This is not going to cause overdoses, but that doesn't mean that our transit operators feel safe at work, and they need to feel safe at work in order to keep us safe as riders. Peter Sandman also talks a lot about outrage factors, and these are emotional factors that influence our perceptions of risk. And they are things such as control. If you have control over the situation, it will feel safer to you. If you feel like a risk is voluntary, you are choosing to take it, it will feel safer to you. Morality, something that's morally wrong, people may tend to think is not as safe. If the risk is not fairly distributed, people are going to feel that it is not safe. And if they don't trust the people who are tasked with solving the problem. So these are all factors that we saw at play in this scenario. The bus drivers feel like they did not have any control over what was happening. It was completely involuntary. For many, it was morally wrong. We shouldn't be allowing smoking at all. They didn't trust the agencies to solve the problems, and it felt very unfairly distributed on transit. Like no one's smoking on, we would hear people say, no one is smoking on commercial jets. Why are they allowed to smoke on buses? And Peter Sandman again says the most important truth in risk communication is the exceedingly low correlation between whether a risk is dangerous and whether it is upsetting. And again, that's what we saw here. This was very upsetting to the operators. It was minimized by many agencies. It was minimized by many people. And even though it's not, going to land them in the ER for having overdoses, it was upsetting to them and should be acknowledged. So to kind of follow up on this work, we did a risk perception study with 273 transit operators in the Pacific Northwest in the autumn of 2023. And this was a mixed methods investigation of the self-reported frequency of observing these events, the mental, physical, and psychosocial self-reported impacts that transit operators have upon witnessing drug use events, transit operator intent to leave, their stress, their job satisfaction. We looked at what risk perceptions they hold around drug use events, and then we did a qualitative exploration of existing supports, workplace safety, climate, and culture, their needs, their experiences, and outrage factors. So I'm going to give just a few kind of highlights that we found from that work that we're still working through a little bit, and some of these papers are in review. So from our survey, which, this was surely like any survey, there's going to be some selection bias, but 84% of respondents reported observing drug use on their vehicle in the last year, and 65% reported that it was occurring multiple times per week. 43% reported feeling burned out at least weekly. 75% reported being very unsatisfied about how their employer responded to passenger drug use aboard transit vehicles. 75% reported feeling somewhat or very unsafe at work, and more than half reported being somewhat or very likely to leave their job in a year. So not a happy group that took our survey, and not for for something vital such as public transportation. You want to have people that want to work there, stick around, feel safe and supported. I will say that many transit operators also held beliefs that inhalation or dermal exposures on transit could cause extreme sickness, overdose, or death, which is not true. So there were also some kind of tightly held beliefs about exposure that were likely feeling some of the outrage that they felt. I'm just going to give a few little tidbits from our qualitative study before wrapping up. So one operator told us, "I would like management chiefs, superintendents, the general managers take it more serious than what they did. They're sitting in their offices and not boots on the ground, and they have no idea what we're going through. They hear it, but they don't know for sure, and they didn't do anything. It would have been nice to have some support for them to protect this." And this really points to the fact that things like not trusting the process and not having trust in the agencies were outrage factors that operators were experiencing. Other operators told us, "Drug smoking creates the feeling that you are trapped, feeling like a hostage having to breathe it in. And when passengers use drugs, it would make me mad because I knew that there's nothing I could do." So this points to kind of a lack of control as a potential outrage factor that's impacting the operators. And another says, "I don't recall explicitly seeing people using drugs on my bus, but that's not to say that they don't. The problem is you're trying to navigate the bus, and taking your eyes off the road to watch what passengers are doing is a precarious exercise." So this just is a reminder that the outcomes we are concerned about as occupational health researchers are not just the physical outcomes from breathing in drug smoke, but also the safety impacts that can influence the operators and the drivers. So we still have a lot to learn. This is an emerging hazard, and it really represents interests from both public health as a whole and occupational health as a part of public health, and it really requires, team-based approaches. And there's more work needed on what appropriate health supportive community and occupational interventions look like. But in my opinion, this needs to be done while acknowledging that transit operators, like all workers, have the right to a safe and healthy workplace that is free from known hazards. So here's my contact information. I also have a final report that was written for the transit agencies. We have 2 papers published from this and another in review. So if you're interested in seeing those, please contact me. And I will end with our long list of acknowledgements because we receive so much help from folks across UW, from the transit agencies, and of course from the transit operators. And that's my end, David.
Oh, thank you so much, Marissa. That was that was a very, very interesting study with both technical and public health communication challenges. So I appreciate your presentation today. As a reminder, if you have questions, please just write them in the chat and I can read them out loud, or request the microphone to Justin so you can ask them directly to Marissa. There's a question in the chat from Leslie. So what other industries has drug exposure of public access jobs been examined? And there's a comment. Note that the newly developed National Safety Council overdose emergency tool include public access as one of the 5 input factors that go into the calculation of the number of doses of naloxone a workplace should have on hand. So there's a link there. We will have, the Institute will have an event coming up on recovery-friendly workplaces. So we'll make sure that you'll have that information, Marissa, but you can also share with your department and students.
Yeah.
Yeah.
Leslie, nice. Thank you for your question. Nice to see you. So when this project started, we started to hear from a lot of workers and learned that this is not only transit operators who are experiencing this. One group we heard from quite a bit is libraries. So, folks will come in, often there are bathrooms available in libraries. People will use the libraries and will, the librarians who, just like the transit operators are not EMTs, will often, be responding to overdose events or, just erratic behavior or smoke exposures and things like that. It's also common in ERs. There's a little more training for many people working in ERs to be able to respond. And of course, first responders themselves, police officers, EMTs, paramedics are often, the people responding to these events.
Yeah, Marissa, I would also, I was given permission to speak. I felt like I couldn't speak.
Yay.
Okay, I much prefer to speak than to write. Also, I would think about other industries such as hospitality, and I mean this is just such an important issue. And I was basically involved, and I did most of the research for that went into the National Safety Council calculator. So it's a big deal that really access and public access to the workplace really came up as a critical factor. So I think that there's many workplaces with a kind of on a continuum with different degrees of public access, and which ultimately are directly tied to exposure that could be, considered and thought about. But thank you. Great work. Appreciate it.
Yeah, that's great to hear that public access is a consideration. One thing I will say about naloxone is it's not every transit operators don't necessarily, not all of them see that as a solution. They're like, the solution is not that I should now be responsible for someone's life on my bus because they're smoking. The solution should be they shouldn't be on the bus. So some of it is, there are some operators who are like, I carry naloxone and I'm happy to use it. And there are others who say, I have no interest in being a first responder and I don't want it. I don't want anything about it. So some of it is,